everybody. All right, so we're going to jump into Module 3's lecture. I do want to let you know that this is probably one where you may want to pace yourself and maybe take a few breaks. There's a lot of content in here, and I feel like I say that all the time, but this one is a little bit disjointed, so just keep that in mind. Remember, you can hit pause and you can come back if you're feeling overwhelmed, which is one of the perks of having a narrated lecture versus having it in person. All right, so Module 3, we're going to go through the very most common basic health disruptions of our kiddos by age and stage, okay? And then integrated within that is some of our specialty information regarding palliative care and mental health / mood disorders. So we're going to start with the health problem of our infants. All right, so when we're thinking about vitamin imbalances, at our most basic thing, right, vitamins, we need that. Some of us take it, some of us don't. All of us probably should because we live in Alaska. And why is that? Because vitamin D deficiency is so common in Alaska in both children, adolescents, and adults. We just don't get enough sunlight. And so who is at the most risk for a vitamin D deficiency? That's going to be your exclusively sorry, my pen fell down the side of the couch. Exclusively breastfed babies. And why? So let's think about that. So if we have moms who are vitamin D deficient themselves, and then we have babies who get their nutrition from mom, and with understanding that our kiddos, our infants are not going to be sitting outside getting 12 hours of sunlight a day, that's going to bring that into play. Then we have our kiddos with darker complexions, and with that comes an issue of urban living as well. Because it's especially more challenging for our kiddos with darker complexions to obtain enough sunlight to get enough vitamin D. And so additional considerations include urban living because of things like pollution, lack of like good direct sunlight, and then let's see, so living above or below a latitude of 33 degrees north and south. That sounds so silly and kind of seems out of place on the page. But if you think about that, the sunlight that the people are getting who live in those areas the sunlight doesn't produce enough vitamin D to sustain the levels that individuals need. And then additionally, our kiddos who are overweight or obese. And so vitamin D is so important. I pretty much educate my patients every month. So I do monthly med checks for the teenagers that I work with, and I review their medications with them on a monthly basis. And almost 100% of them, I mean, there's very few and far between teenagers who aren't on vitamin D that I see because their levels are so low. And I'm always telling them, why is this important? Do you remember? Can you tell me why it's important? And so there's two things going on here when we talk about vitamin D. Vitamin D is important for our babies, obviously, for their growth, for bones, for things like that. But vitamin D also impacts your emotional regulation. In primary care, if somebody comes in with some symptoms of depression, now I'm talking adults, if they come in with symptoms of depression, something that's going to almost always be run right away is a vitamin D level. Because when your vitamin D is low, you can have symptoms of depression, but it's not a chemical imbalance in your brain, it's having low vitamin D. So obviously, very important. The other piece to this, and you don't have to know this for your exam, but it is good information. Let me back up to vitamin D. Our kiddos who are exclusively breastfed, a way that we try to combat this is to either have mom taking vitamin D and or, depending on mom's levels, babies should be getting 400 IU of vitamin D. And to give you some frame of reference, if you're not aware of what the adolescent and adult IU recommendation is for vitamin D a day. It's up to 2,000 IU. So I take 2,000 IU around the year, even in the summer, just because I don't always get outside as much as I would like. Sometimes we have really cloudy summers, and that's what I prescribe to my teenagers, 2,000 IU once a day. Okay? That's for your knowledge. That's not necessarily on the exam as far as the requirement for dosing, but just something to be aware of. Most people will take 1,000 IU a day and be okay. If you have really low levels, like I did when I came here, because I lived in Chicago and Michigan, which isn't all that much different as far as weather goes, 2,000 is a good place to be. Okay, so moving on. Other vitamin imbalances that are important. So we've got iron deficiencies, vitamin A, and vitamin B12. Those are important. I think everyone's probably aware of iron. We know that that's important. Vitamin A is something that kind of catches people off balance sometimes. And I try to remind students and patients and their families, if you can't remember anything else about vitamin A, remember that that's something that is really important in pregnancies. But you can also have too much vitamin A, and that can be just as bad as not having enough. And then vitamin B12, that's another common one, especially with alternative diets like veganism and being vegetarian. So very common, very healthy, but there's just different things to take into consideration. So, and so here, an 8-year-old child is eating a purely vegetarian and or vegan diet, and I know that they're different, but for this purpose I wanted to highlight that it could be both. And so which of these does it have to include? And so the answer is C, vitamin D and vitamin B12. Now I want you guys to think about that, consider it, look it up, chew on it. And if you're confused on why, then I want you to email me. But this is one that I want you to be able to think about, okay? And so it's vitamin D and B12. Okay, so thinking about what is it that we are going to do as nurses, your pediatric nurse in this scenario, when it comes to those vitamin imbalances. 1, growth charts. So those don't go away after we first talked about them. And I know in the last week's recording I had mentioned that there's 2 different charts. And so the one I showed you was the CDC, and that's for ages 2 to technically 19 and 364 days of age. And then for our infants and toddlers under 2, the World Health Organization is the one that houses that. And I think I forgot to say that. So why are we talking about growth charts again? Because we want to look at that trend. That piece doesn't go away either. So, we are more interested in seeing where they're plotting as they go. We want to encourage breastfeeding if possible for at least 6 months. And so, why? I've kind of mentioned it already. Obviously, even though there's a risk for vitamin D deficiency in kiddos who are breastfed exclusively, there's ways to combat that. Very simple, very easy ways. And so breast is best. This is still, the AAP recommendation. Though if breastfeeding cannot occur, it's not the end of the world. There are plenty of fortified formulas that can do the same thing when we're thinking about these vitamin and other imbalance type things. But here, encouraging breastfeeding for at least 6 months. So if you've got a mom who's kind of on the edge and she's like, I just don't know if I can make it, this is one piece that you can include in your education as another reason why this is so helpful. And when I say this, I mean breastfeeding. So up to 6 months is where we're hoping for, because at that point, at 6 months, we can start introducing foods to our kiddos. Now, the literature and the book both say fortified solid foods can start anywhere from age 4 to 6 months. Most providers are still going to go with the recommendation of 6 months. I typically still recommend 6 months. It really just depends, again, on their development and their growth. And so let's think about that. Why would growth and development matter to being able to start foods, solid foods? Well, if the jaw doesn't work the way it's supposed to, if an infant's tongue, if they're not doing the tongue protrusion, so sticking their tongue on tongue, blah, 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 like that, probably without the sound, those are indicators that introduction of solids could start. And why is that important? Well, because if you put food in a 3-month-old mouth, if you put any kind of solid, they're just kind of gonna go, they're not gonna have the coordination and the literal functioning yet to coordinate closing the mouth, using the tongue to swallow, pushing that food back without choking. It's just not there. So again, some will say as early as 4 months. My typical recommendation is 6 months, with the caveat of knowing your child and watching for those indicators that they're ready. Now it says fortified, and that is really important because we want iron fortified foods so that they're getting iron. And iron fortified cereals, the recommendation is actually to continue that for at least 18 months so that they're getting the fortification of the iron in cereal, in addition to other foods that you will start introducing to these kiddos that have iron naturally. And that's an important piece. And if parents choose to continue exclusively breastfeeding after 4 months, though we really encourage parents not to introduce foods, not to wait to introduce foods for after 6 months, but sometimes it happens and then we need to have a plan for that. So for your knowledge, what we recommend is iron supplementation of 1 mg per kg per day if mom continues to exclusively breastfeed after 4 months. The reasoning behind that is physiologically, fetal iron stores run out at about 4 months. So there's a little bit of lag time there. Between that 4 to 6 months, I'll have parents say, well, I really just want to wait till 6 months. Do I have to start iron? The answer is no, you don't have to. But keep in mind that their fetal iron stores run out at 4 months. So mom's diet should include a good amount of iron if it doesn't. Or some parents are willing to take the gamble. They don't want to give their baby another supplement if they're already doing vitamin D or something like that. And then they just wait because they're planning to start feeding them at some point between 4 and 6 months. Okay, so again, like I said, iron supplementation is needed for anemia and for prevention. I'm not going to ask you that dose, but iron is a weight-based as well, so keep that in mind. Iron's important. There can be a lot of issues if there's not enough iron, and from the right sources as well. Let's see. Okay. The chapters in the book, there's also some info about severe malnutrition, marasmus, and kwashiorkor. You guys don't need to know that. Just know that those are severe types of malnutrition. Usually it's in like our younger oncology patients or severely maltreated children or children with unresolved or unknown, undiagnosed, however you want to call it, malabsorption issues that can't be resolved. So that was our vitamin imbalances. Very common, especially discussion of that and anticipatory guidance in that format from the health promotion standpoint, and on the all the well checks up to a year. So now another really common, increasingly common topic in the clinic is food sensitivities. I see this a lot, way more than I thought there would be in my clinicals for my NP, and even, so with the younger kids, and then now working exclusively with teenagers, I see it way more than I thought I would with them as well. So let's break some of this down. So food allergens or sensitivity. This is an IgE-mediated immune response. So something like a cow's milk allergy, which you can see at the bottom, is an adverse systemic and local GI reaction to the protein in cow's milk. So that's a true IgE issue. Okay, so we have a allergy to that. Okay. And so when we're talking about food allergens, those are specific components or ingredients in food, such as proteins, that are recognized by your allergen-specific immune cells. And so that's bringing it back to patho, thinking about the different types of immunologies, your IgG, IgE, all of that business, your immune-mediated responses, and what that means. So then we have an intolerance. So that's a non-IgE mediated response. True lactose intolerance, there is no immunologic reaction within the body. It's just something that your body's like, oh, sorry, not happening. So in thinking about the difference, if you need to think outside the IgE issue, one way to think about it is the food intolerance is always going to elicit a reproducible adverse reaction. So kiddos and teens with lactose intolerance, they're going to have the same symptoms happen every single time. It's not just once and then it gets worse. It's not anaphylaxis. It's just an intolerance. Your body's like, nope, sorry, we're not having this. And if we do, here's what happens. Gas, nausea, belching, those are all common symptoms of lactose intolerance. And so what's interesting, when I said that I have way more exposure to this food intolerance, sensitivity, allergen conversation with teenagers, it's really the lactose intolerance. So again, I work with a mental health population, and so we'll have a lot to say about that later on in the PowerPoint. But there's one or two things happening, because I'm seeing teens of all ages ranging from 12 to 18 who have never had to take like the Lactaid pills before, which has the enzyme to break this stuff down that they can't when it's a true food intolerance for lactose. They come to me, they've never been on Lactaid, and then suddenly they get to the unit and they're gassy. They're complaining about being gassy when they have dairy, or maybe it's just one kind of dairy, so yogurt or milk or cheese. And so I go through that. I go through that with them. Is it all dairy? Is it one kind of dairy? Is a reaction worse with one kind of dairy versus another? And sometimes there's really good answers and it seems very obvious. And then other times I can't help but wonder if, especially where I work with a mental health illness population, if they just think it's cool. Everybody else takes a Lactaid before dinner. I want to take one too. So there's a lot of pieces to determining allergens versus sensitivity versus intolerance. And I'm spending so much time on this because it is a huge piece in pediatrics right now. It doesn't matter what area you're working, whether it's inpatient, outpatient, school-based, community-based, nutrition, huge priority for peds. And so if we have these nuanced areas where there's issues, you as the nurse, even just the generalist nurse, not the pediatric specialist nurse, have to be aware of these pieces. So box 10.1, I wasn't going to list them all, and you don't need to memorize it, but I would take a look at it. These are the common allergenic foods and sources. And what's interesting about that is the National Immunologic and Allergy, I think it's Disease Council. Anyways, one of the big societies, the organizations that deals with allergies and kind of these issues, feels and has recommendations based on the common allergenic foods and sources. And so interesting things that come from that are kind of these recommendations similar to like a clinical practice guideline or pretty much like clinical practice guideline. So it has all of the recommendations of what they think and based on what evidence, et cetera, et cetera. A few things that I found interesting out of this were that they recommend, even in kiddos who have an egg allergy, get vaccines with egg products like the MMR series. And that things like mom's diet, from a prevention standpoint, has no impact on developing a sensitivity or having an intolerance. From the prevention standpoint, after something's going on, then yeah, they might look at that a little bit more closely. But from prevention, especially moms that are, exclusively breastfeeding, they don't have to cut things out because they're afraid if they have dairy, then their kiddo is going to have dairy. If there is an issue, that's something different. But from, this anticipatory guidance, breastfeeding nutrition viewpoint, they don't need to do anything different, aside from eating healthy, of course, but nothing related to food sensitivities. Okay. So then we have atopy. Some people call it atopy, atopy. There's all sorts of pronunciations of it, so don't feel bad if you're not sure which one it is. And so this is a food sensitivity that is more hereditary and is part of like a whole cascade of issues. But basically, kiddos who have the atopy reaction, we know that this is where the increased risk of anaphylaxis is. So, and I said that this is a hereditary component, absolutely. So if there's one parent who has a severe actual allergy or sensitivity, especially an anaphylactic reaction to something like, let's say, peanuts, there's a 50% chance that the kiddo is going to have it. But if by chance both parents have a severe or anaphylactic peanut allergy, there's a 100% chance that that kiddo is going to have it. And so this is where we are worrying kind of about, okay, well, now we have to watch them closely, see where this goes, plan for an anticipated anaphylactic reaction if they ever do happen to accidentally try something with that particular food allergen in it. Because remember, things aren't always obvious, and that's why the little disclaimer that this could have come into contact with peanuts started, because things that aren't peanutty or you think wouldn't have nuts in it can come into contact with that. Okay, so now, what do we do as nurses? So one of the biggest pieces here is the health education. And I have this a little out of order. But from the health education standpoint, this is huge. The pediatric nurse with a kiddo with a food allergen or a sensitivity or an anaphylactic reaction, that nurse has got to be educating everybody. It's not just the parents in the clinic that day, but it is teachers, daycare workers, areas where kiddos are going to be on a regular basis, especially if they're eating. I wanted to mention here, the EpiPen, PRN. So not everybody with a food sensitivity is going to need an EpiPen because they're not all going to have an anaphylactic reaction. But just for your knowledge, there's two different kind of formulations here. EpiPen Junior is for our kiddos, it's weight-based, go figure. It's for our kiddos from 8 to 25 kilos. And one single dose in an EpiPen Junior is going to be 0.15 milligrams. And obviously it's IM. Our regular EpiPen non-junior, which is what adults also get, contains 0.3 milligrams, and it's for those who are 25 kilos or over. So just keep that in mind. Even something like this is weight-based. There's going to be one piece of the discussion later on that is not weight-based, and I will make sure you recognize that. And so the other piece to this is the assessment and history gathering, so important. I mean, when we're talking about nutrition and food and things that people have come into contact with, the more thorough and comprehensive the history is, the better information and likely correct diagnosis is going to be made. And as now we're jumping into the health disruptions of kids, I'm going to tell you the secret. It might get me kicked out of the club, but 90% of pediatric diagnoses are made based on the history. It's few and far between that I don't at least have my top 3 diagnoses in mind, just based off the history, even without the physical assessment information. And that's why as we continue to go through, when we're talking about classic symptoms, what questions are you going to ask parents, what history pieces are you going to be gathering, there's such an emphasis on that because the history holds such a high priority in establishing the correct care for a kiddo. And then the other piece here is referrals for allergy testing. Now, despite what very concerned parents who come into the clinic will say, not every child needs a referral for allergy testing. There are specific criteria which you don't need to know, so they're not listed, but just know not everybody needs to go to the allergy clinic. But those that do, we want to get them there quickly and make sure that that process is happening appropriately. Okay, so now that we've covered some of the nutritional imbalance pieces that come from the allergen type side, let's move on and talk about failure to thrive. So failure to thrive does not have a universal definition of what it is and how to diagnose it, which I found really surprising as a pediatric nurse practitioner student. I was just like, how is something like this that's so important not have a universal definition? Well, the experiences that I had as a student, particularly at South Central Foundation, really highlighted that for me. So let's look at these 3 boxes here and see if you might, in your mind, before I give you the answer, come up with a theme. So in failure to thrive, there's 3 potential sources or reasons that it can happen. So 1, inadequate caloric intake, inadequate caloric absorption, or excessive caloric expenditure. So obviously, we're talking about failure to thrive, so that includes things with calories, because we know that nutrition is the most important thing for our infants, for their growth. Remember, intro, module 2, those pieces connecting yet? I hope so. So the theme here is basically the inability to obtain or use enough calories. So not obtaining it would be poor intake, not using it would be poor absorption, and then the caloric expenditure would be not obtaining enough for how much is being used. And so again, let me go, nope, not skin. So couple things to keep in mind. Just like I've been saying for everything, I'm sure I sound like the broken record at this point. When we're looking at failure to thrive and having the potential for that being a diagnosis for a kiddo, are we looking at one day where they come in, or are we looking at a couple of times? And so we're looking at the trend. Again, the trend. So typically your kiddo, while there's no universal definition or diagnostic criteria, is an infant who's at the 90th percentile for weight and maintaining that gonna be considered failure to thrive? No, they're definitely getting enough calories. So typically, as a rule of thumb, it's going to be any kiddo who has a weight below the 5 percentile range. And I've seen some providers and talked to some who are a little more conservative, or meaning by that they will go to the 3%, meaning that they think that 5% is okay. And so it really just kind of depends on clinical judgment and an array of things. But for your purposes, thinking anybody who's under 5% who has, a trend under that 5% is something that we want to look at. Now again, on that trend piece, if we're seeing a kiddo who comes in and they're at 5%, and they continue to drop, and then they're under 3, and then they sustain that under 3, that's a trend. Is that a trend that we're worried about? Yes, we want to know what's going on. On the flip side, I've seen kiddos come in under 3% and maintain that, whether they're straight on that 3% curve or there's a little variation, one time it's above it, next time it's just below and above, then it's on it. I had a patient like that as a student, as an NP student, and I was concerned with what I was seeing on the growth chart, but I looked to my preceptor and I said, you've been seeing this kid for a while. Looks like you've seen this family for a while, because my preceptor was very well established at the clinic that I was at. What is your take on something like this? I think that it's concerning, but what's the rest of the history? And that's why that is so important. And for this particular kiddo, despite the fact that she was consistently at 3% or under, the family history of her siblings, and some other biometric markers like percentage of fat and other things, this family just has small babies. And as long as you are assessing nutrition and maintaining that weight trend, that's okay. And so that comes back to partly explain why there's no universal definition of what failure to thrive is, because if it was always just this hard and fast rule, every kid that's 3% or under is failure to thrive, that wouldn't be, and it sounds silly to say, but it wouldn't be fair, right? And it wouldn't necessarily be accurate. On the other hand, if you have a kiddo who's in a neglect situation, which I've seen, and they come in at 3%, and then we're concerned, so we're going to have them come back in the next day or two, and they're still dropping, and dropping, and dropping, and maybe some of the developmental pieces aren't there. They're a little listless. They're not as active as they should be. And now we're concerned. So it's all about that history and assessment gathering, whether you're the nurse practitioner, the physician, or the pediatric nurse. Getting this good history is going to be important. Another point of note here when we're talking about failure to thrive too is catch-up growth. So what I mean by that is our kids who are born as low birth weight or very low birth weight, they have a hard time catching up, especially if there's other things going on. So that's, again, the history piece, birth history, which should actually be included in all assessments up to kiddos 3 years of age. That birth history is so important too. So what do we do then as the pediatric nurse in helping to manage, or what does our nursing care look like for these kiddos? Well, the number one thing is going to be reversing the cause. So if they're not getting enough intake, there's a couple reasons. It could be parental ignorance. They just don't know how much they're supposed to be feeding, and I see that a lot. Thinking that feeding them every couple of hours is just too much. Or what's very common that I saw, especially in the Anchorage area, was babies who were good sleepers. Parents didn't want to wake them up. They thought, oh, they need their sleep, I should let the baby sleep. When actually your infant needs to be woken up and they need to feed about every 2 hours or so. So that's plain and simple, just parent or caregiver not knowing. Another common one, due to low socioeconomic status, is not having a good enough concentration of formula. So families, in an effort to make expensive formula last, will dilute it down and add more water than they should, or not pack the cup. So there's a lot of educational pieces that go in here, and this connects back to that anticipatory guidance piece and why it is so important that that's also included at every visit, every contact you have with a parent. Inadequate caloric absorption. So now from a medical perspective, we're going to be ruling out any kind of organic cause. So is there intestinal malabsorption? Is there something else going on? Is it an endocrine issue? So those are the kinds of things that they'll be looking at for that piece. And just consider too, if you're the nurse, what are some reasons that you would want to advocate, especially from an outpatient perspective as the outpatient nurse? What are some things or reasons that you would want to advocate for hospitalization or for more interventions to occur than just let's bring them back in a couple days? Well, what are your big ones? Safety, so abuse, if we're concerned about a neglect situation, and also dehydration. So super big issue. And whether that is parental ignorance or maliciousness is notwithstanding. If abuse or dehydration are occurring, we want that kiddo, 1, in the hospital to be monitored, 2, to do some nutritional therapy, get them some fluids, get them the calories that they need, okay? And this is where you're going to call on your team of resources. Social workers, especially if you're working at a place like South Central Foundation where they have that interdisciplinary team right there in the clinic, wonderful to have. Nutritionists, dietitians, they are also great resources. So remember, you're not standalone. You are not the island and the only one taking care of the kiddo. You're the inpatient nurse. You have all of those resources at your disposal. You just have to advocate for the use of them. And so I realize I'm like 36 minutes and we're on to like 2 or 3 slides, but there's so many pieces that connect back to these disruptions from week 1 and week 2, and you're going to continue to see how that happens as we move forward, because you really do need to understand kind of this circle of things that are happening and help that inform the way that you're thinking through these issues, both on the exam and in real life. So next one, common skin issues. Wow, so a lot going on here. And I know there's at least a handful of you that have kiddos, and I am sure that you have seen an unknown rash at least once or twice in your life. Again, because we're going to focus in this one on the common things, we're going to talk about stuff that has a name to it. So, diaper dermatitis. Prolonged repetitive contact with some kind of irritant. The peak age for this is between 9 and 12 months old. I want you to think about why that is where it happens the most. So think about that as I'm talking about these next pieces. Diaper dermatitis also has an increased frequency in our bottle-fed kiddos compared to the breastfed kiddos. Now, prolonged exposure. Okay, that can mean a lot of things. But why? Why does that prolonged exposure? What, aside from being on the skin, what is happening? And the answer to that is friction. Especially, here's your answer, that 9 to 12 month old, if they're developmentally on track, they're going to start moving. Versus our, oh, sorry about that. They're moving, they're mobile. They're trying to scoop, they're crawling, or they've started walking. So there's more friction and abrasive damage between that dry, smooth skin and the irritant. So you're going to get irritation. There's also greater skin permeability, and we know that just kind of in general about kids. And then there is an increase in the microbes present in the diaper, obviously. Another thing that can contribute to that is increased urine pH. So depending upon what kiddo's eating or drinking or what's going on with the urine, that has a lot to do with it. Just like diaper dermatitis is going to be almost guaranteed if you've got a kiddo with a viral illness who has diarrhea. Because again, that acidic pH sitting in there, you got the germies just percolating, and it is just truly a good setup, unfortunately, for diaper dermatitis on top of whatever else is already going on. So where does it happen? The fancy answer is on the convex surfaces, which translates into the folds down there. Think about that again. perfect place. Constant friction. If there's a little bit of urine in that kind of inguinal fold area between genitals and thigh, that's also where the rim of the diaper is, and you have a kiddo who's now running around like a frantic savage, dermatitis. Other things that can cause it to be in non-convex surfaces are wipes. And I saw this a lot. So much so that I am now, as a pregnant woman, I've asked for nobody to give me any wipes in their various baby gifts, because I'm so concerned about the chemicals in them and just kind of the reactions, because I've seen it. The other piece is, especially as the popularity of these rises, is the cloth diapers. If they're not properly washed, either that means that there is like retained fecal matter, or that the urine wasn't completely washed out of it, or that the soap or the fabric softener, if they're using that on there, which they should in non-cloth diapers, if that's not being rinsed out appropriately. Oh, but thinking about the wipes thing, it kind of poses a catch-22 situation for parents. Well, if the chemicals in the wipes are irritating kiddo's skin, but not wiping them will cause more dermatitis, what do they have left to do? And honestly, for the kiddos who have such severe reactions, or just such severe diaper dermatitis from, let's say, a diarrheal episode, we just think it doesn't have to smell nice as far as the wipes. They have that nice scent to it. But that also means that there's chemicals in there. Cotton balls and water will also wash off feces and urine. And I've recommended that to families more times than I ever thought I would. Have had them follow up, and it worked. Do they go back to the wipes? Yes. But when there's an appropriate amount of elimination from a kiddo, then there's not an increased frequency of use of the wipes. So this is where all of that critical thinking, again, really comes in. How do we recommend to families? Well, if reason A, wipes, are the reason and cause for the health disruption, which is diaper dermatitis, but we know that leaving it on there will make it worse, what do we do? And this is where some of your basic stuff comes back. Water and cotton balls. And that's the kind of thinking that I want you guys to start beginning to do if you're not already. In pediatrics, you're going to hear me say a lot. Sometimes it's just back to the basics. Remember, least invasive first. So we're using the most basic stuff that we can to get the best results. Cotton balls and water are an example for helping with diaper dermatitis. All right. The other piece to that too with diaper dermatitis, and I'm actually going to jump ahead here real quick because I couldn't fit it on this one, is yeast. And so when we're thinking about common skin stuff, yeast infections are also very common. It's not listed on there because I wanted you to focus more on diaper dermatitis, but when, if you were in the clinic and you had two back-to-back kids and they looked like this, these look very similar, but there's enough nuanced differences to tell me that they're not. So this picture on the right here, this picture on the left is a diaper dermatitis. And so what we're seeing, thinking about what we just said, here in the folds, areas where there's going to be high exposure to the irritants, so the poor little genitals, and that does look very painful, and kind of this outline of where it is. Okay. Then when we're thinking about yeast, there's a pronounced difference in the look here. And if you can't see it, I'm going to explain it. So this photo with the yeast, also known as Candida albicans, it's a beefy red color. And there's a little, you may not be able to see it, but I'm telling you there's a maculopapular rash here. So little tiny bumps at your basic term, little tiny bumps, and then you have satellite lesions. So all of this is congregated right here where the contact is, where it's wet and moist and dark, and then you've got a couple of lesions up here that don't really fit in with the rest of how this looks. We're in diaper dermatitis, these are still all very much connected, except for maybe that guy. I mean, here you're going to see more satellite lesions. Okay, so just remember that difference. Thinking about, see how the folds up here, see that's gone, or that's not present, like here, where the mechanism of action here is the irritant, where the mechanism of action here is actually the yeast, the candida. Wet, moist, in contact with it, versus up in the folds where there's contact everywhere. Okay. All right. So now moving on, switching gears a little bit, atopic dermatitis is also known as eczema. Sorry, I lost my train of thought. So there's kind of three ways that we talk about it. It's infantile, childhood, or pre-adolescent/adolescent, and that indicates the age of onset. Usually, when people think of eczema, they think of like the dry, itchy skin. But actually, eczema is the descriptive category of a group of dermatology diseases, and is not actually a specific etiology. So that's something to keep in mind. Okay, that's why atopic dermatitis will encompass a lot of things, and eczema is what most people think is the diagnosis, but the diagnosis is actually atopic dermatitis. So just a little aside for you guys. But how do you know the difference between something like a diaper dermatitis or an eczema if it's severe eczema? And one of the big differences, just kind of in general, that sets eczema apart is that there is intense pruritus or itching, and dry skin. You can have dry skin without it being eczema, but if you have itchy dry skin, it's almost always eczema, especially in our little kiddos. And I see that a lot here because it's so dry, and in the winter it's even drier. It's a very, very common issue here in Alaska. And so there's in this box, which again, I think all these boxes are really great study tools, so I point them out. There's more clinical manifestations, but truly the hallmark is the intense itching and dry, rough skin. And so treatment of this is going to be based upon the presentation. And so as the nurse, what does that mean? That means that you're going to be doing a lot of education. Okay. So hydration of skin is the #1 way to treat and prevent eczema from flaring and getting bad. Our other goal is to minimize itching so that scratching does not occur, so that secondary infection doesn't happen or another flare-up. And so from the nursing perspective, that means educating parents on avoiding irritants, talking about how to prevent your kiddo from overheating because sweat will also irritate and cause a flare-up, talking about good hygiene for kids, keeping their nails short because eventually they're going to scratch. But if the nails are short and clean, there's a less likely of a chance for infection. So medication-wise, that you would be educating on side effects and uses and things like that. First line is going to be topical stuff, obviously. So topical antihistamines for the itch, topical steroids if it's severe enough, and if there's a secondary infection, you're going to be educating about topical antibiotics. Other things that you'll be educating about is the home environment. So mild detergents, how frequently to be washing bedding and cleaning upholstery, especially if there's pets in the house. And the other big piece, and this is the start of another repetitive thing you're going to hear, is addressing family coping. Because remember, right now we are talking about focusing on our infant issues, And so if you've got an infant with eczema and it's itchy, can you imagine how they're going to communicate that to you? Through a lot of crying. And so how is the family coping with this? Do they have extra support? Is there anything that you can do as the nurse to help facilitate referrals or anything else that might be helpful? Not excluding the family, because remember, family patient-centered care is important here. We want to make sure that they are up to snuff on everything that's going on. And then seborrheic dermatitis, all I need you to know is the difference in like diaper dermatitis and atopic dermatitis, and that's that it's a chronic recurrent inflammatory reaction. So more commonly known as like cradle cap. That's considered seborrheic dermatitis. Otitis externa, so ear infection of the outer part of the ear versus inner middle ear, also seborrheic dermatitis. So just know that one so you'll be able to know the difference. Okay, we looked at that guy. Oh, sorry, I forgot I added this one in here. So here's your slide with all of the things that I was talking about as far as nursing management. Notice again, thorough history is number 1. Okay, so moving on to colic. This one I have a lot less information for you to have and know about, and that's because some of these things I really just want you to kind of know what it is versus diving deep into the pathophys. For some things in kids, we just don't know the full pathophys, and this is one of them. So colic is a disorder of, it's also known as a disorder of unknown etiology. We don't know a lot about it other than what it looks like when it's happening. So colic, paroxysmal abdominal pain, happens in 5 to 20% of all infants, and the diagnosis is going to occur when they're younger than 3 months. It's more prevalent, so occurring more often in our preterms, our small for gestational age babies, and occurring in the infant that it's happening, it's more prevalent to occur later in the afternoon versus in the morning. Helpful diagnosis pieces or parts of the history that should trigger you as a nurse to think like, could it be colic? The 3 C's. Crying more than 3 hours per day, more than 3 days per week, for more than 3 weeks. And the thing about colic is that the kiddos continue to gain weight and they're thriving. They're just crying all the time. And like I said, we just don't know exactly what it's from. And so in colic, and I keep saying it, the history is so important. Because for example, some moms choose not to drink any coffee or caffeinated beverages in their pregnancy, but then they deliver and they're like, oh yes, caffeine, I'm on it. But they're breastfeeding. So the infant is then getting used to the caffeine and caffeine withdrawals. Those kiddos are pretty cranky. So there's a lot of crying and a lot of irritability versus the mom who drank coffee, because you can have up to, 200 milligrams of caffeine a day when you're pregnant, and have it be safe, versus those moms who drank the coffee and they breastfeed and they're drinking coffee while they breastfeed, or tea or whatever your caffeinated beverage of choice is. Those kiddos are going to be much less irritable and cranky related to the caffeine. But if you are the nurse and you're getting a history and talking to family, and you're getting elements of their diet and mom's diet, that's something that would help you kind of make that determination. Because then that's not colic, and that's a caffeine baby who is adjusting to the caffeine life versus the well-adjusted caffeine baby. Other things that you would be gathering and making sure that you hit on as the nurse assessing this is time of day when the crying occurs, right? Because I said in the afternoon is when it's most likely to be occurring when it's colic. Sorry, my dog's doing something weird and it's distracting. Relationship of crying to feeding time. Also, finding out what's going on with the family members. Who's present when the crying occurs? What are they doing? Smoking. Do family members smoke around the babies? And is this crying occurring only when there's smoke around? So things like that. So that's when I'm talking about history taking and assessment, those are the kinds of things that you as the nurse would be doing, or gathering rather. Okay, so let's move on to some common sleep issues. Again, these ones I really just want you guys to be aware of kind of what they are in general. I don't need you to be experts on them or talk to me about the neurology behind it. Okay, I paused it because my dog was doing the weird thing and it was super, super distracting and I had to make him stop. So I think I was saying that I don't need you to be experts in this stuff. I just kind of want you to be aware of the differences in them, and that's why they're listed out here. Table 10.1 also lists out the common sleep problems really well. But the ones that I'm going to focus on in the next slide or so are the ones that I want you to be more educated on, essentially. Okay, so SIDS is actually considered, or sudden infant death syndrome, for anyone who didn't know, SIDS is actually considered part of a sleep issue. Despite that, we still don't know exactly why SIDS happens. Okay, what we do know instead are risk factors. So maternal smoking, co-sleeping, so parents sleeping with baby in the bed, not with one of those cool attached to the bed bassinets, but like in the bed. Prone sleeping, and I hope everybody remembers, prone would be on the tummy. Supine sleeping is like a cup of soup that you're holding in your hands. At least that's how I still remember it. Arrhythmias can actually also be a risk factor for this. Having extra soft bedding in there, so all of the cute plushy stuff and all the lots of pillows, like how my bed is set up, not okay for babies. Low birth weight, male gender, and American Indian heritage has actually also been found to be a risk factor for SIDS. What we do know as well, some protective factors and some recommendations by the American Academy of Pediatrics, is that breastfeeding and pacifier use have been found to be protective factors. So SIDS rates are occurring less often in kiddos who are being breastfed and using pacifiers. Back to sleep, so like I was saying, the supine sleeping position, we are putting babies on their backs. That's why it's called Back to Sleep. Get it? Get it? That campaign was kicked off, I don't even remember how long ago, but I've been hearing about it since I was in undergrad nursing school, so it's been a while. Babies, when they sleep on their back, SIDS rates are reduced. And then, again, removing that extra bedding. So basically doing everything that you as the parent or you as the nurse or a combination thereof, everything that you can do. And then sometimes, unfortunately, and what is so traumatic about SIDS for the caregivers is you can do everything right and it still may just occur. So back to sleep and the bedding, pacifier use, because some people think that those are bad, that's all part of anticipatory guidance. And that's why it's so important, even if it's a mom who's just had their 5th child, still provide the anticipatory guidance about all of the important pieces. Now, with the Back to Sleep campaign came an increase in plagiocephaly. So plagiocephaly is an oblique or asymmetrical head. So there's a couple of different etiologies for plagiocephaly. The one that I want you to be most aware of is positional plagiocephaly. That's from the kid having a weird shaped head or an asymmetrically shaped head. I shouldn't say weird. It's not very trauma informed. I apologize. An asymmetrical shaped head from either laying on the back, so it's kind of got a flat back, or what's more common, like in this photo, an infant will have a preferred side, just like we do. And so we'll either roll their head to the right or to the left. And this is where plagiocephaly can then lead to something called torticollis. So what may happen is on the preferential side, so if a kiddo likes to sleep like this on their back with their head to the right, that sternocleidomastoid muscle right in here can actually tighten up. And then the infant is always kind of looking this way. Their eyes will track back and forth when they hear mom or whoever, moving, but their head is pretty much always on this side. And so that's torticollis. And so, I keep jumping ahead. Sorry. I get a little excited. And so in torticollis, what the treatment for that is so exercises to loosen things, trying to get the unfavored side to be utilized more often as much as possible with that tightness in there. And some kiddos, the combination of that and then tummy time is not enough. And so then physical therapy is needed. And I know that sounds scary, and for parents, especially the new parents, oh my gosh, you know, my 2-month-old infant needs physical therapy. But it's truly not something to be scared of. So providing a lot of reassurance to these families is really important. They didn't do anything wrong. They're doing the right things. It's just something that happens because the sutures, so the soft spots, you know, soft spots, anterior, posterior, squishy, you feel them, good indicators of things like dehydration and whatnot. They have soft spots because their suture lines are not fully closed, and that's so that they can get out the birth canal. And so it's just something that happens, and we know that, and we have plans for that, and that's sending kiddos to PT. And then if physical therapy is not enough to correct it, and sometimes it's not, then we put kiddos in a little helmet so that it reshapes their head. It looks horrible, but it's not. You know, they're so young, they're just more irritated by it than like if a teenager had to wear a helmet like this for some reason. Very different perception, right? Age and stage, age and stage. So in a kiddo who has to wear this helmet, they're going to be prescribed to wear it 23 hours a day. And that is going to be that the helmet is going to occur if there's no improvement in the torticollis and the overall plagiocephaly. So does the head kind of reshape itself now that it's not always just on that preferred side, after 2 to 3 months. At that point, if they've done the least invasive stuff, so they've tried the tummy time and the repositioning and trying to use blankets to keep it on the top of the head to keep it kind of where you want it, then they go to physical therapy. If that's not better after 2 to 3 months, then we'll put a kiddo in a helmet, and that usually has really good results. Okay. One more piece that I want to just barely touch on so that you know what it is, because we're always thinking about safety and life-threatening things. A parent life-threatening event, or an ALTE, is basically a near-miss SIDS. Whether that happens with parent walking in and seeing the kiddo exhibiting some of these signs, or however the situation comes to be. It is a very serious situation and requires significant intervention, like 911 right now. And when that has good outcomes, so interventions were implemented, kiddo is saved, those kiddos are discharged home with an apnea monitor to monitor their breathing and see what's going on, and then parents are actually taught how to administer CPR if they didn't already know. That's basically the bit that I want you to know about that. There's more info in the book, but this is, again, one of those things you need to be aware of, but at this point I don't feel that you need to know all of the super ins and outs of it. Okay, so next age and stage, we have toddlers and preschoolers, and it's combined. So let's jump into that. All right, so let's move on. Okay, so sleep problems are coming up again. Remember how that's a big topic in health promotion? So it's one that we're going to continue to talk about as sleep problems arise in each age and stage. So for our toddlers and our preschoolers, this is a huge time for sleep problems to occur. The main ones being nightmares and sleep terrors. And it's related to this, both of them are related to this multifactorial cascade of rationales and reasons. One, you know, thinking about our toddler and our preschooler, both are wanting to become more autonomous and have more say-so in things going on in the family. So the increasing autonomy impacts this. Negative sleep associations also start to develop at this point. Nighttime fears, afraid of the dark, afraid of things under the bed, that kind of thing. But also on the other side of this is parental components. So inconsistent bedtime routines and lack of limit setting can really also impact some of the sleep problems that occur. And media use. Media use is a big issue. It's coming up a lot in the literature. How media is used, for how often, when, what types, etc. So basically any of your negatively recommended pieces of media and what that looks like. Just like we know as adults, checking our phones right before we go to bed actually activates the brain and doesn't help us sleep. Same thing works with kids. So, nightmares. They will remember them if they're old enough. They see the dream as a real fear, and it typically occurs in the second half of the night, so when they're in deep REM sleep. Sleep terrors, on the other hand, these kids who have terrors will have no memory of the dream or thrashing around. They are unable to be comforted or consoled, and the sleep terrors will usually occur shortly after falling asleep. So even just looking at this description, you can see the big differences in the nuances here. So your kiddo with a sleep terror, they are going to wake up screaming and they're going to thrash, and almost anything that you can do as the parent or the caregiver or the nurse witnessing this, there's not much that you can do to wake them up. They just have to write out the dream or the terror. And then afterwards, they won't remember. Everyone else will be very upset, but the kiddo won't remember. Nightmares, they're going to remember them. And this is where some of that seeing the dream as a real fear starts to manifest. And this is, again, happening in the second half of the night. And so interventions for these are going to be based on the cause. As when we're talking about interventions for sleep problems, that's going to be related to the cause. The biggest recommendation for addressing sleep problems is good sleep hygiene. Setting a good routine before they go to bed. Getting kids to relax. And I know that sounds like an oxymoron, especially toddler and preschool age. But there are things that can be done. I've seen it be successful. But it takes a lot of time. And this is not something that we just, write a script for. We don't give sleep aids to little kids, usually. So this is something that family has to really set and maintain. Next, we've talked about diaper dermatitis and we've talked about atopic dermatitis, and now we're going to talk about contact dermatitis. So contact dermatitis, is an inflammatory reaction that usually is going to occur on the parts of your body that's most exposed. Arms, legs, forearms, and male genitalia. Why would male genitalia be part of this? Think about that. We'll come back to it in a second. And so, like I said, inflammatory reaction to coming into contact with chemical substances, whether they're natural or synthetic. And so we're having, I say we, but the people who have this, our kiddos, are having a hypersensitivity response, a direct irritation as a result of something that they came into contact with. So if we're thinking about parts of the body where this commonly occurs, again, hands, arms, legs, forearms, male genitalia. Boys and girls go to the bathroom differently, right? Well, if a little boy is running around in the middle of summer touching everything that's outside, and then he goes pee, his hands are going to come into contact with his genitalia. Also, little boys, especially toddlers, are more likely to put their hands in their diaper than little girls. I'm not saying it doesn't happen with girls, but it is more common with the boys. And so that's how their genitalia ends up with contact dermatitis. So when you're doing an assessment here, there's some classic pieces for contact dermatitis that are going to be very different than like the your ATP look or the diaper dermatitis. And so one of that being that there's this classic sharp line of demarcation. You can very clearly see where the irritant touched the skin and where it didn't. And so that line and that erythema that results from the contact can range from just a transient erythema, so just it's kind of red, to severe, serious, large bullae or fluid-filled pockets on an erythematous swollen base. And usually, contact dermatitis is itchy. Then there's this piece of primary versus a sensitizing agent. So we're thinking anyone who comes into contact with something like something super itchy. Poison ivy, that'd be one example. Cow parsnip, that'd be another example, one closer to home. Anyone who touches that is going to have an issue. Versus the sensitizing agent, thinking more somebody has touched this before, they're now touching it again, and there has been an immunologic change since the first time they touched it, and now it takes less time or amount of the sensitizing agent or contact with that agent to have as severe of a reaction. So it continues to get worse every time. I mentioned cow parsnip. That's really common here in Alaska. I moved to Alaska about 4 years ago. I came to Anchorage about 3 years ago, and I had no idea what cow parsnip was or devil's club was until I did my PNP clinicals, and it happened to be the bulk of those were over the summer. I had no clue. My preceptor had to Google it for me and show me pictures when we had our first onslaught of cow parsnip cases. I got to lance a lot of really cool looking bullae. Some really cool ones where they was like pressurized and like squirted all the way out, and then some were just kind of weeps. But again, that's, and actually, to be most accurate, something like a cow parsnip is going to be more of the phytodermatitis because it has that chemical on it that's then UV activated. But we think along the lines of contact dermatitis there because they're touching something. So a little bit of a distinction, but I wanted you to think you brush up against it, you can have a reaction. And that's true for anybody in the garden, especially if you're an avid gardener or an avid hiker and you're not wearing long pants. You can come into contact with various different types of plants, various different substances, and have no idea which one it was. You know, the common question here too is like, did you switch soaps, detergents, body washes, things like that. I have a latex sensitivity, and it is more to the powder that comes in the latex gloves. I learned this in nursing school, so I had it was a sensitizing agent for me. The first time I put on the old latex gloves, it was an old kit, you know, they gave us the old supplies for skills lab actually. I put the gloves on, you know, did my stuff, took them off, and I was like, my hands kind of feel funny. But I didn't really think it was related to either the latex or the powder in the gloves. Never wore them again until I was a nurse in my first job, and I think it was a cath. I think I was placing a catheter, and my gloves, my sterile gloves that came in the kit, fell on the floor. So somebody brought me a pair, and it happened to be like an older pair of latex sterile gloves with the powder in it. Well, from that first time that I had worn the gloves in undergrad and then had not had any other exposure to it until I was a nurse, I had an immunologic change due to the powder. Because when I took those gloves off and I washed my hands, I had, they were red, they were puffy, they had like the macular, slightly papular rash. But when I had touched things previously that had latex in it, like the tourniquets for blood draws, no issue. So I had, you know, talked to other nurses obviously, and had talked to the other people, and it's the powder in the latex gloves. So it's very interesting how that immunologic change happens from just one exposure to another. And then, if you think about that, that brings you back to thinking about that's the food allergens in the same way. You eat it once and it's kind of fine. You eat it something again, or you come into contact with something again, and it's 10 times worse. And I've had the same issue with bee stings. Each time I've got stung by a bee, my reaction to it was worse, and now I have an EpiPen. So that's not necessarily contact dermatitis, but the same kind of sensitizing, increasing immunologic response is. Okay, so that's contact dermatitis. Briefly, we would be remiss if I did not mention poisoning, because thinking safety, big priorities. Toddlers, preschoolers, especially toddlers, they want to put everything in their mouth. Sorry, lots of talking today. We're at 1:15. Okay. So, poisoning. Most common in children younger than 6. They're at the biggest risk for injury. And this ranges from personal care products to gas. I mean, plants, foreign bodies, toys, miscellaneous substances. I mean, it's almost anything. Okay. It's not just your cleaning products or your medications. Plants, indoor house plants, plants outside. Kids put everything in their mouths. So this is something that connects back to that anticipatory guidance piece. So when you have a toddler, and when you're about to have a toddler at that age or stage prior, as the nurse, you're going to start educating about this. Get families thinking about it, because it's very scary when parents have to call the poisoning hotline. And I put it there, the Poison Control Center. It's an easy number, but just FYI, that's for your knowledge, not for any exam needed knowledge. I think it's helpful to give out the magnets at like a well child visit. That way they can just slap it on their fridge and don't have to worry about the number getting lost or erased or whatever. I have actually had to call the Poison Control Center, I don't know, maybe 2 or 3 times, and it was related to my adolescent patients eating Tide Pods when the Tide Pod thing was happening. They weren't supervised well enough when they were doing laundry, and they downed some pods. They had chemical burns on their mouth, but otherwise had no other issues. And so the other point to putting the Poison Control Center on there, as a nurse, if you get asked this question by a parent, or if you're providing that anticipatory guidance, what are you going to say? The very first thing, if a parent even has a suspicion that their child ingested something, they need to call Poison Control Center first, because they are going to have the information. I have talked to ER nurses that have ended up calling the Poison Control Center. So number one thing to do and advise families is to call the Poison Control Center number, because in the office too, I've had parents call the triage line, which I was answering as a student. The office doesn't know. We don't have all of the info on the types of things, and we direct them to the Poison Control Center. So that's the spiel on poisoning. Now we're going to move into child maltreatment. So a heavy topic for a lot of people. At this point, if you need a break, I would take a break before you jump into this, and I wouldn't have little kiddos around, okay? So, child maltreatment, and this is coming to you in the toddler and preschool age section, but truly it could fit anywhere, and we're going to talk about why. So, child neglect is the most common type of child maltreatment. And about 50% of cases, of all child neglect cases, are kids 5 and under. So that's why it's sitting here. But again, child maltreatment could fit and does fit in any age and stage. So please keep that in mind. So we're talking about physical, psychological, emotional. I have emotional both times. I meant to put mental. So physical, emotional, mental, or psychological abuse. No, I meant to put sexual. Man, killing it today. Physical, sexual, emotional, or psychological abuse. That all makes up child maltreatment. Okay. Give you a bit of a breakdown. Neglect is, like I said, the most common, and that accounts for about 60% of all child maltreatment cases. Intentional physical abuse is about 11%. Emotional abuse or emotional neglect is about 4%, and then sexual abuse of children is about 8%. Those are your national averages. I can tell you, though it's not, you don't need to know it, and that's why I don't have it up here for the exam. Alaskan rates are higher than that. We have, oh, I should have checked before I recorded this. We have, I'm not going to quote it, so I don't want to be wrong, but I know confidently that we have one of the highest child maltreatment rates in the nation. I can't recall if we are the highest still or if that's changed, so that's what I don't want to quote to you. But know that we have exceedingly high rates. I worked as a forensic nurse in multiple states, and I can tell you that I struggled as a nurse working in Alaska as a forensic nurse because there were so many more kid cases. And what I was seeing was mostly teenagers. Before I was a nurse practitioner, this was when I was working as a nurse, it was mostly teenagers dealing with healthy relationships, consent, boundary setting, peer pressure, lack of education, just kind of in general about what a healthy relationship looks like. Wanting to just be loved, being taken advantage of by older individuals, the use of social media like Instagram, TikTok, Snapchat, all of those things contribute to the rates, essentially. And so abusive head trauma denotes its own little spot here because it is so severe when it does happen. It's a serious form of PA, physical abuse, in infants and younger children. And this is why, again, child maltreatment can fit into any age and stage bucket. But abusive head trauma is more common in our infants and young children. Why? Because they don't talk, they don't speak, and they cry. That's their main form of communication. In our infants, they cry, and so shaken baby syndrome. Now, abusive head trauma is very serious because thinking about that pathophys here, the coup counter coup, anybody remember that? Like being rear-ended, your brain is bouncing around, plus the amount of force for somebody to wrap their hands around a rib cage, which although is bone, is a very tender bone, and so it's very dangerous. Thinking back to that coup counter coup head motion, subdural hemorrhage, epidural hemorrhage, hematomas. There's a lot that can happen to the brain that happens very quickly and can have lasting effects. And so as the pediatric nurse and as a mandated reporter, period, this is so important, okay? A very hard topic, but very important topic to remember, that you are always on the lookout, always on the lookout, always assessing for any kind of abuse. And if you suspect it, it needs to be reported, okay? All right, so then moving down, so we have some considerations here. Parental, child, and environmental considerations when we're talking about child maltreatment. So one of the biggest reasons that it occurs is parental or caregiver substance abuse. Families who are isolated and have a lack of resources. Children who are nonverbal and or have disabilities, making them more vulnerable. And a stressful home environment. All of these things contribute and increase the risks of what the likelihood of child maltreatment occurring is. And I think, okay, so we're going to talk a little bit more about each of these just so that you have, I'd be remiss if we didn't, basically. So sexual abuse, it encompasses, and this should be a review, because I know that in 315 you get this. Incest, molestation, exhibitionism, child pornography, child prostitution, and pedophilia. Boxes 3, 13.5, and 13.6, again, review. It should be review. But warning signs of abuse and clinical manifestations of child maltreatment are there. So things like inconsistent histories, sudden change in mood, sudden change in elimination control, injuries that don't match, sexualized behaviors, all of those things encompassed in there. Okay. And I'm going to go back to this slide. So a couple other things here that I want to really stress in child maltreatment with the mandated reporter piece, which again should be review. I didn't teach it this summer, so I can't confidently say that it was there, but I know when I taught it every other time, we speak about it there when we're talking about the family. As a mandated reporter, you are required by law, despite how you feel, or your own personal biases, or history, or experiences, whether positive or negative, with OCS, to make that report. There are multiple ways to make a report. Calling, they now have an encrypted safe email. I believe the fax number is still provided. You can always talk to a live person when you're making a report. They don't want you to know that on the telephone system, but it is. And actually, today is September 1st. That's when I'm recording this. As of today, I believe the mandated reporting laws in Alaska have changed. You can find in-depth details if you're interested enough about knowing it now, but the gist of it is that now, in addition to making a report to OCS, when you're suspecting child abuse, you also have to report to law enforcement. Typically, this would happen anyways in the way that the team works together, but not always. Excuse me, not always. So now you have to do both as a mandated reporter. The other thing that I want to say about this as a mandated reporter, especially when we're talking about children and making reports about vulnerable children, is you never want to make them feel like they did something wrong. So something that you're going to see illustrated in the learning activity case studies is what do you say to a child who has just made a disclosure to you? What is it that you do or don't do? And I want you to think on that, and hopefully you're watching this and then you'll go do the learning activities, and then you're going to get the answers from me where I talk about those things. But chew on that, think about it, put together what you know about mandated reporting, put together what you know about children, and really put some effort into those answers on that practice, the learning activity case studies. And then, like I said, there's going to be a video about those posted with the answers. And please review that and take a good listen. And then come back to this information and kind of piece it back together like a puzzle if you had any gaps. Because it's very important, both for the exam and for your future practice, no matter what area you're in. Okay? All right, so that's my spiel on that. So now, health problems of school-age children and adolescents. And I see that I'm already at an hour and a half, and we are just about to dive into my absolute favorite topic in pediatrics, my area of expertise. This is what I did, the adolescent part. This is what I did my DNP project on. This is the area that I work in now. So I promise to try to still stay on track. But I could talk for multiple classes just about some of the things that we're about to talk about. So with that in mind, okay, we're going to start with problems of elimination. This is so common. And again, this was something that was very surprising to me just as a pediatric nurse, that this was something that continued to happen or that happened so frequently. And then as a nurse practitioner, the amount of times that I encountered this in clinic was just mind-blowing to me. And now with my work in trauma and mental health, I just actually diagnosed somebody with nocturnal enuresis last week. So it's very common. So enuresis is bedwetting, and then nocturnal enuresis is nocturnal bedwetting. It is, like I said, very common. It has to occur at least once a month for 3 consecutive months at the minimum for the diagnosis to be made. And then there's primary versus secondary. So enuresis, we've got intentional or involuntary passage of urine beyond the age of when bladder control should be established. Okay, so when I'm saying primary means that it was never established. And then secondary would be that there was an established period of time where bladder control existed, and then suddenly it's gone. It can be monosymptomatic or polysymptomatic, so it can just be bedwetting. It can be accidents during the day, or it can be accidents during day and night. So nighttime would be monosymptomatic, polysymptomatic would be daytime and nighttime. And it's very important to have organic causes ruled out. So UTIs, functional bladder capacity, other urologic issues. We want to make sure that there's nothing physically, organically going on. Same thing with encopresis. Oh, sorry, I skipped ahead. You got to know how to treat it and what your role is, right? So in our kiddos with actual enuresis, whether it's primary or secondary, there are several treatments. The most common one that I find in practice and in the literature and in the book is medications. So desmopressin, that's one. And then there are a few other ones, oxybutynin. I actually just prescribed desmopressin for somebody today. A 12-year-old boy who's having bedwetting issues. And you recognize, too, think about the age that we're talking about, school age and adolescence. So they're starting to establish that self-identity. They're starting to care about what friends think. They're having social lives, spending nights overnight. So these problems of elimination can cause a lot of issues for our patients who have them. And so with that, there's a lot of family support that is needed for, but there's a lot of support that's needed, both for the family and for the patient. And the nurse is able to offer that. Same thing with encopresis. So encopresis, if enuresis is urine, encopresis is going to be the repeated involuntary passage of bowel movements in inappropriate places or settings. Just like enuresis, it has to occur at least once a month for at least 3 months. And in this one, the child has to actually be at least 4 years old chronologically. And again, primary versus secondary. It never occurred as far as control, or there was an established period of time where there was control, and then suddenly that control was gone. One of the most common causes of encopresis is actually constipation, because kids are full of poop. That was another surprising thing to me when I started my clinicals as a nurse practitioner. I did not realize how common constipation is. And that spans the age ranges, because I feel like I deal with constipation from a medical perspective with my patients now, the teenagers, more than anything else. Kids don't like to poop. There's a lot of pieces to that. But with such severe constipation, the intestines do all sorts of things. There's reabsorption of water. The muscle movement is different. The peristalsis. And so there can be times where constipation is so severe that it can, one, actually look like it can be diarrhea, and then two, can result in the uncontrollable passage of fecal matter. So they can have an accident right in the middle of the store, and there would be literally nothing that they meaning the patient, could do about it. That's how severe it can be. And so that's the number one reason for encopresis. Then there is voluntary withholding, and that's usually also related to constipation because it hurts, because the fecal matter is so hard because of all of that reabsorption, so it's very painful. And then there's this pain withholding cycle that kids go through. The other piece is there can actually be, again, an organic component to this. So issues with the thyroid, Hirschsprung's disease, and we're going to get into those more when we get to the GI thing. But these are common enough for you all to need to have it on your radar now. Okay, then there's also, and I don't have it listed here because this is for your knowledge, it's not going to be part of the exam, psychogenic encopresis. So that is related to emotional issues. And so I see psychogenic encopresis a lot. And it can be very challenging, especially in the tween age, 10, 11, 12, that's a really hard time. Especially when you start thinking about social things like overnight camps, spending the night at friends' houses, in Alaska, camping, hunting, fishing trips. That can be a really big stressor for both the patient and the family. So, treatment, initially it's going to be a bowel cleanse. I prescribe this, again, more than I ever thought I would. You just have to start over. If the constipation is so bad, and a lot of times I will get an x-ray to confirm the full amount of constipation just to be sure. But at that point, kids got to get cleaned out and you got to start over, literally. And it actually takes time, can be about 3 months for the intestine to shrink back down, because if there's severe constipation, think about it, it's literally full, so that muscle is stretched out. I said that the peristalsis is different, so basically your intestine has to just fully reset, and that takes about 3 months. So kids will be on like a Miralax regimen to make sure that they stay regular. They have to increase fiber, kind of all of those pieces that go with constipation. But that's just a piece of this. And then, again, a big part of your role as the nurse would be educating and setting up referrals for things like family counseling, because there's going to be a component for that too. So I have been telling you that the exams are going to be kind of this comprehensive way of looking at all of these things that we've been talking about: communication, therapeutic relationships, critical thinking, etc., etc. So I'm going to give you an example. So a mother of a 7-year-old is doing laundry and notices that her son has 3 pairs of pajamas in the hamper. After checking the bed, she realizes that he is actually wetting the bed at night. How should the mother approach the problem of her 7-year-old's bedding? So this is very close to what kind of that application exam question I'm talking about would have. On your exam, the only short answer questions are going to be the math calculations so that I can see what you're doing. But everything else will be select all that apply, or fill in the blank, or multiple choice. For this, it's a case study, so it's set up to be short answer. So I will give you the answer, but I really want you to think through what I'm saying and how it applies to kind of all of these pieces that we have been talking about. So again, how are you then, the nurse, going to advise and talk to and educate the mom about what she should be saying to her kiddo? And here we go. So providing advice, providing education, counseling, whether it's you to the parent and it stays there, or then parent to go on to the kid, we always have to consider the developmental age. So this kiddo is 7. You would have turned in your Erickson. So you should know then that he is in this industry versus inferiority stage. So he wants to be strong and competent and make the achievements that he wants to make. So if he feels that whether it's the way that mom approaches this with him, or by putting him down, or just kind of the guilt and shame that might go with this, and that's why he hasn't talked about it. If he feels inadequate or inferior, he's feeling like he's not going to meet the parents' expectations of him, or the standards that they set for him, or the social standards of being, the only one that he probably knows of having accidents at night at 7. So, it's going to be very important then for the nurse to recommend that this mom does not compare him to any siblings, if there are, or relatives, or other children his age, because that would be really detrimental, making that kind of comparison. Well, if your older brother Tommy didn't have this issue, why are you? Not therapeutic, not helpful, not developmentally appropriate as far as meeting the favorable outcome. Because it's always our goal, no matter what we're talking about, whether it's us talking to the child or us educating the parent on how to talk to the child, what is developmentally appropriate? What are they trying to achieve? And what are we trying to make sure that they don't result in? The other piece to this, especially if there are siblings in the home, is school age and adolescence are a big time for competitiveness to start emerging. And so if a parent were to compare their child to another sibling, that really sets the tone for some negative competitiveness. There's healthy competitiveness and then there's negative. When it comes to health and something like this, that would not be healthy. So we're advising developmentally appropriate conversations. We're making sure that family does not do any kind of competitive comparativeness. And like I've been saying, there could be an organic cause. So, you've got to remember that you want to encourage families to bring their kiddo in, or at least call the triage line. Hey, this is what's going on. And you could be the triage nurse in this situation, or you could be the friend who's a nurse that the family is coming to, the mom's coming to, like, hey, I got this going on. What do I do? And whether it's peds or adults, it's going to happen so often that, believe me, it's going to happen. So figuring out how to talk to people now appropriately and providing the right advice for families and your friends is going to be important. So referring this family to their pediatrician, something like a simple UTI could be causing it. And that's where that primary versus secondary comes in, and making sure that diagnostics and stuff are ordered to rule out organic causes. Because a simple fix like an antibiotic for UTI would be able to take care of this. And I don't recall if I said this, so you may not have thought it, but we're going to address it now. Nocturnal enuresis is actually, it has a strong familial or hereditary component to it. So getting that good history is essential. And that might not be something that families talk about with each other. And that's why here it's worth mentioning specifically, because how many of you on the first, second, third, even a couple years in with your spouse or partner talked about, hey, did you ever wet the bed after you learned how to sleep through the night without having accidents? It's not like a commonly talked about thing until something like this comes up. Okay, so then what strategies should the nurse discuss with parents to help improve the problem of enuresis? Not related to the example up top here. This is just a standalone question. And so, because I just love those boxes, I'm going to refer you to box 17-1 because it has a lot of really great things in there. But some other ones and things that I actually just discussed with my patient: emptying the bladder right before bed, restricting fluids at night after the nighttime meal, depending upon the child and the day's activities, to a very minimal. We're looking anywhere from 7 to 10 ounces. Avoiding fruit and juice after 4 o'clock. Why? There's a lot of sugar in those, and that actually you pee more. And if you're eating something that's a water-based fruit, like a watermelon, that's more fluids. Okay, good, but still fluids. We're trying to avoid caffeinated beverages after 4 o'clock. Caffeine can make you urinate more. If a kiddo is thirsty before bed, how do you manage that? Compromise. Small sips. Not a big gulp. I remember the first time I offered a child as a nurse small sips when I was working on the inpatient floor. It was like 2 in the morning. I filled the whole cup, like the small Dixie cup. Yeah, he drank the whole thing. And so after that, I learned you offer as much as you're willing for them to have. That's my pro tip there. If you only want this kid to take a very small sip, that is how much you put in that cup. Okay. What else? Allowing the kiddo to wear regular sleepwear is important. Again, this goes back to age and stage. We're talking about children and adolescents, so putting them in diapers, pull-ups, the benefit versus the drawback here is not great enough to do that. So bear that in mind, because it seems like it would be something that a family might think would be common sense, right? They're having accidents, so let's not ruin the bed, and let's put them in a pull-up. But that's not the route you want to go. Let's see. Similar to the other one, obviously, appropriate age and stage. You don't want to scold them because, again, this is an involuntary issue, not their fault, not doing it on purpose. Keeping a calendar of dry versus wet nights can be helpful to pinpoint if this is something related to stress or an emotional disturbance, something like that would be helpful. Okay, there's a ton more, but that's just to give you an idea of how all of this rolls together, okay? All right, so moving on. All right, okay, so switching gears a little bit. Now we're going to talk about ADHD and learning disabilities. This comes up in the school age and adolescent topic. Kind of mismatched, but not really. So ADHD really truly has to be diagnosed before age 12 for it to be considered ADHD. Otherwise, there's some other factors that go into that. So keep that in your mind, age 12. And that's why the first box here, early identification and assessment, is imperative. As the nurse, the school nurse primarily here, but also if you were an inpatient and had a kiddo that came to you for something totally unrelated. But the school nurse is really going to have a big piece here. Kiddos with ADHD and LD or learning disabilities, which are not synonymous. You can have ADHD without having a learning disability, but they do frequently co-occur, just FYI. Either way, these kiddos are at greater risk for other issues like anxiety, depression, ODD, conduct disorders, and so this assessment and early identification, just like everything else, is so important, but it's truly important because a lot of these things can look very similar. One can be mistaken for the other. This is an area that I work extensively with, and so I don't want to overload you with information that you don't actually need for your exam. So if anyone's interested in talking further about ADHD and learning disabilities with me, please reach out, but I'm going to try really hard to stick to these boxes. So normal childhood behaviors versus symptoms of ADHD. They look very similar. Important differences are things that fall under, again, developmentally appropriate behavior. Is it developmentally appropriate if you sat in the back row of church or at some kind of meeting where there's children intermixed, and you can see all the little kiddos kind of squirming in their chairs because it's an hour-long thing and they just kind of don't care? Yes, that's developmentally appropriate. It would not, however, be developmentally appropriate for, you know, a 6-year-old to not be able to stay in the chair, for them to continue to jump up, despite what, you know, parents are advising them and setting limits on. That's not so developmentally appropriate. Same thing in school. At 6, 7, 8, when the teacher asks the child to stay in your seat, for the most part, that is what is expected. Especially when redirection and guidance is given. They, after the first time, she'll learn, okay, if I get up when I'm not supposed to, I will get in trouble and I should not do this. Kiddos with ADHD really struggle with that. That's the big one that I want to stress, the developmentally appropriate piece. So when we're talking about ADHD, there are 3 main types, which is this bottom row here. There's combined type, there's predominantly inattentive, and then predominantly hyperactive impulsive type. What I really want to stress too, and this is not in your book, but I want you to know this moving forward for your own future practice, is that kiddos, especially the ones that are diagnosed at a young age, they will usually, with age, progress kind of through this spectrum. So when they're diagnosed at 6 or 7, they could be predominantly hyperactive and impulsive. And perhaps by the time they reach 14 or 15, suddenly now they're more inattentive. So that's something I want you to know. It's not going to be in your exam, but it's something I want you to know. A big piece of the nursing role here, and again, we're really going to hit on the school nurses because that's where this would really be highlighted in the nursing considerations. Coordinating services, acting as a liaison, communicating with the primary care provider if that's who's managing, or the psychiatrist, whoever that may be, if it's complex ADHD. Providing education to the child, to the family, to teachers, pretty much everybody that's working with the kiddo. That's really important. The other piece would be administering meds, especially if a kiddo has like an afternoon short-acting dose or whatever the case may be. And then assessment. If this kiddo is on some kind of a stimulant med, and we're going to get into that in a second, then there would be a big piece of the nursing role here that would be assessment. Same thing in the clinic. When they come back in for their checkup after they need a new script for their meds. Big piece on assessing for side effects and sustainability and effectiveness. Here. So this is more or less for your knowledge. I want you to know that there are stimulants and non-stimulants. Stimulants obviously then come with more side effects than non-stimulants. And side effects for kind of all of the stimulants here would include insomnia, so not being able to sleep, anorexia, not being hungry, and that's a big one, so then that's associated with weight loss, and then hypertension, because it's a stimulant, vasoconstriction, blood pressure goes up, etc., etc. And so that's a big concern for families, especially anyone who's had past experience, perhaps, maybe, because ADHD, there is a familial tendency as well. Maybe the parent had a bad experience with being on a stimulant, or they're afraid of stigma, which is a big piece. So there's a lot of education, very sensitive education, particularly with culture and stuff as well too, around this, okay? And so that assessment piece, the nurse is going to, are they eating their lunch? Are they losing weight? Or do they look like skin and bones? Those pieces. And then vital signs. What are some signs of hypertension? Maybe a kiddo just gets their blood pressure regularly checked just in case. It varies from child to child. But something I want to stress, very important, ADHD pharmacology, ADHD meds are not weight-based. They are symptomatically based. So we start at a low dose and look for the most effective dose possible based on the safe dose range, and then we move up based on need for control of the symptoms, not weight-based, okay? Like Concerta, a good starting dose on Concerta, which is a long-acting stimulant, is 17 milligrams. We see how they do on that. I have kids that are up to like 38 milligrams on some of the stimulants, and that's been titrated up over a period of time. Again, not weight-based. I can't stress that one enough, because everything else that we've talked about so far has been weight-based for the most part. Okay, so male reproductive issues. Here, what I really want you to focus on is understanding which ones are a life-threatening emergency and which ones are not. And so testicular torsion, life-threatening emergency. A child or teenager can lose a testicle based upon poor response time to testicular torsion. So it's exactly what it sounds like. The testicle has twisted on the spermatic cord. And what happens then? Think about that. Why would this be life-threatening? How could they lose that? If there's twisting, blood supply. The blood supply is cut off, okay? Big issue. Big issue. We're not going to go into any further on the pathophys of that or signs and symptoms, because there's, again, so much info in this one. I just, again, broad overview, want you to understand it. If you hear it, that's a big deal. She told me that that was a big deal. We should do something about that. Infection or an inflammatory reaction is epididymitis, not life-threatening, but does need to be treated with antibiotics most often. And testicular torsion epididymitis can mirror symptoms. So pain, swelling, both common. Then we also have varicocele, which are an elongation or dilation of the spermatic cord above the testicle. And then, sorry, brain fart, breast enlargement or gynecomastia. This is actually a very common thing. Happens in about 50% of all males in the adolescent age range. Huge issue as far as body image and self-worth. So each of these things here, when we're talking about male reproductive issues in school age and adolescent child, we're ranging from life-threatening to the perception of being social life-threatening by the patient. And so this is where understanding how your communication as a nurse has to function. Up here from, I need you to do this, this, and this now, down to understanding that a teenage boy with breast enlargement is going to need a very different communication style than something where you need them to listen to you right this moment, do this now. And I just want you to understand that and be aware of it, okay? All right, similarly with female reproductive issues, getting a broad overview, slightly more detail, but again, broad overview. So amenorrhea, no period. So there's primary, meaning that there's been no secondary sex characteristics and no onset of the menstrual cycle by age 14 to 15. And then secondary, which is significantly more common. So that's absence of menses for 6 months or absence of 3 cycles after menstruation was previously established. The most common cause of secondary amenorrhea is pregnancy, even among teenagers. But that's just kind of an FYI. So then there's dysmenorrhea. So if amenorrhea means that there's no period, dysmenorrhea means that there's a dysfunction, right? So it can be very painful, or it can also be very irregular. It can be both of those things. I see this a lot. I think about 99% of my teenage patients have dysmenorrhea of some form, or varying degrees of severity, rather, is what I wanted to say there. So some treatment options for dysmenorrhea is what you're seeing here. NSAIDs, estrogen, oral contraceptives, dietary changes, exercises, and symptomatic comfort measures. That's what I want you to know about that. And then vaginal infections. So this can be physical, chemical, or infectious. And so that brings us to our STIs. STIs, so sexually transmitted infections, are going hand in hand with risky sexual behaviors. Huge issue. Not really getting better. We're not going into this very in-depth as far as pathophys stuff. So no, you're bacterial. We've got chlamydia and gonorrhea. Protozoal is your trichomonas, trick. Viral, we've got HPV, HSV1 and 2, so cold sores, or genital herpes, though now HSV1 and 2 are very interchangeable. Your hepatitis and HIV. Adolescent pregnancy, still a big issue. Contraception, availability of it, accessibility of it, both condoms and like spermicide, but then also hormonal contraception. Such an issue. I struggle with that in my practice because adolescents have reproductive health rights, and their reproductive health is they're able to have autonomous decision-making power over that if they're cognitively competent. Each state actually has a different age for this. Some as low as 12, some are at 14, and then some have some kind of restricted decision-making and related to elective abortive procedures and things like that. For your purposes, what I want you to know is that these are the bigger STIs that are occurring. And actually, I'm remiss. I do not have syphilis on here, and that is significantly on the rise in Alaska. Big issue. Big issue. And then untreated STIs can lead to a ton of complications, both for male and female. So just be aware of those pieces. Okay. All right, moving on to obesity. I mentioned at least briefly obesity before. I think it was in week 1 as part of why we talk about health promotion and nutrition just over and over and over and over and over. So here's a little bit more about it. And we're talking about it in the school age and adolescent because that is primarily where the prevalence lays. So BMI is still the most and best recommended way to determine the difference between healthy weight, overweight, and obesity. There are some caveats and exceptions to that, and that's going to be your athletes and your very muscular individuals. So typically men, but definitely can still be girls at this age as well. So bear that in mind when you're calculating a body mass index. Approximately 12.7 million children and teens in the U.S. are considered obese. And we know that obesity in childhood or adolescence then has its own physical sequelae. So we're talking type 2 diabetes, whether that's as a pediatric patient or later on in life. Hypertension, foot issues, gallbladder issues, fatty liver disease, non-alcoholic fatty liver disease, that's NAFLD. I had to think about it for a second. Metabolic syndrome, lots of issues, okay? Physically, big issues that require treatment and follow-up, impact body image, self-worth, those kinds of things. Then there's the emotional impact. Depression, low self-esteem, not wanting to be around other people, anxiety, depression, and then an increased risk of eating disorder development, which we're going to talk about. Figure 16.2, I actually have it right here. I lied. Hold on. 16.2. 17.1. Actually, interesting. I'm pretty sure my book's over there. I thought I pulled 16.2 because this is the complex relationships. Well, when you guys go through it, somebody tell me if this was actually the same thing. Either way, I wanted you to see this as well. That's why I put it in here, as it came out nicely. There's a very, very complex relationship with obesity in our patients. I mean, we're talking about genetic predisposition, metabolic variations like pre-existing diseases or issues, obese infants leading to obese children. Family and cultural impacts can be here, and that usually is a significant challenge. Then we have this guilt and shame, which leads to the psychological pain and low self-esteem, which can lead to eating your feelings or overeating because it makes you feel better in the moment, but then you gain weight. So it's this very vicious cycle for a lot of people. And that's why it is so challenging to kind of break through that complex relationship in there. It's not just a matter of saying you're overweight and you need to eat less so that you can become healthier and live a long life. That's not appropriate. And it's very challenging to talk to families about broaching the topic of being overweight because it is such a sensitive thing. So some nursing considerations. Assessment planning implementation, obviously very kind of common. Hey, sorry, my cat scratching the couch. But with an eye for the assessment planning implementation to diet, exercise, and behavioral and group therapy. So there's, especially in our overweight and obese children, there's almost always a component to a psychological component. And we want to address that so that the whole picture, that complex figure, is being addressed. Then we have medical therapies. That's not really recommended, and neither is surgical therapies. And I've actually had parents ask me that. Well, I had a gastric bypass, or I had, gastric surgery. Can my child just have that, and then they can just be done with it? No, not recommended. Very hazardous. So what we do recommend is increased exercise and diet modification. So when I see children, my school-age children that are obese or overweight, what I tell them is by increasing that exercise, choosing better foods, eating appropriate portions, unless they're already like 17, but I think I just framed it with a school-age child, they're going to have a growth spurt. And so eventually they should even out. If they're high on the growth chart now, they're up here like 95th, 97th percentile in weight, but low on height, maybe 50th, 40th, they will have a growth spurt still. And hopefully then that weight with an increase in height will bring them down to maybe the 75th percentile for weight. So that's what I mean when I say even out. We don't put kids on diets. We don't put them on Weight Watchers. I don't want to say we don't put them on keto, because actually keto diet can be used as a CAM therapy for epilepsy. But we try not to put them on it for something like this. It's eating healthy. It's the whole family. It's exercising. It's this big paradigm that's really hard for families. It can be very challenging. My cat is really trying to be up in my business. I apologize. Okay, so I said that it can lead to eating disorders. The two that I'm going to address. This is probably my wordiest slide, but I wanted to get all of this in one spot to compare. So anorexia on the left, bulimia on the right. Didn't come up well in the title. I believe you're also going to get a lot of this in the psych portion of the course. So I, again, don't want to spend a lot of time on it, but I would feel remiss if we didn't address it. And so anorexia, refusal to maintain a normal body weight. This is done by not eating. And so the mean age of onset is about 13 3/4. It's such a strange data value, but that's what it comes out to be. It can actually range from as early as about 10 up through young adulthood or older. It is considered a life-threatening disorder because of the altered metabolic activity. Severely anorexic women will not have a period. they will actually develop lanugo, like babies in the womb have, because their body temperature can't be regulated appropriately. There's a long cascade of issues. Again, I don't want to dive too deep into that for you today, but I just want you to kind of have this overview. Treatment, nutrition therapy, psychotherapy, pharmacologic therapy. Pharmacologic therapy doesn't have good outcomes. Truly, they don't, because we want people to be able to eat more. So nutrition therapy, we're getting them parenteral nutrition, getting them what they need to get back up to where they're at. Psychotherapy is a big component to a successful anorexia treatment. And again, that's why I'm not going to spend a lot of time on this, because you should get that in psych. All right, bulimia. This is characterized by binge eating with possible purging. It's usually associated with purging behaviors. So overeating and then self-induced vomiting. Signs and symptoms. Weight may actually be normal or even slightly above normal. If it's going on for a very long time, it could be low. Big signs here. The tooth erosion from the vomiting. Esophageal damage also from vomiting. And then a myriad of GI concerns. Psych symptoms, we've got depressed mood, self-deprecating thoughts, anxiety, and then the treatment is very similar to anorexia by getting appropriate nutrition, but I wanted it to be known specifically here, cardiac monitoring is usually indicated because all of that vomiting, it causes so many issues and can really impact the heart too. Obviously, that's what I'm saying. It can impact the heart, and that's why you have to have cardiac monitoring. All right, so I've mentioned it a few times. Adolescent mood disorders, big issue, big issue. This is where I work, the big land that I live in. Many of you in your journals have noted, and there's been a few things along the way that I actually forgot to mention. In the week one's journal, many of you have noted the obesity piece, the healthy eating, no sugary drinks after age 3, and then there was a big eye to attention on the mental health component to the Healthy Alaskan 2030 objectives. And that's because depression, anxiety, and suicide are so prevalent across the nation, but really especially across Alaska. And then we're going to briefly address substance abuse, because again, that should be coming up in your psych portion, but is specifically relevant to this. So, depression. It is very challenging to detect depression in the school-age child. A little less so in the teenager, but still challenging for a myriad of different reasons. Your school-age child probably doesn't have the words that they need to really express how they're feeling and to communicate those emotions. And so this is where the acting out versus communicating how they feel comes into play. In teenagers, what I hear a lot or read in the histories of patients that I'm seeing is that everyone just thought that they were being a moody teenager. And that stereotype is pervasive, and it makes me really angry because not every teenager is moody. To the effect that you would think that their depression is just moodiness. But be that as it may, neurobiologically, teenagers are predisposed to hormonal surges, which leads to moodiness and impulsiveness, all sorts of things. But with that being said, there's still a need to investigate and assess, especially from the nursing perspective. So, different signs and symptoms in adults. Box 16.1, I think it does a really good job of including these things. But big ones that are different: low self-esteem, hopelessness, poor social engagement, and explains bad behavior by personal shortcomings. I think that's huge. I hear it all the time by my patients. I had an angry outburst today because I suck as a person. I'm a horrible person. Those are common things that I hear. I'm stupid and I don't really know anything about feelings, and so I yell at my teacher. Things like that. That's not verbatim, but that's along the lines. Adults with depression, you usually don't hear that. You hear like self-deprecating things, but not usually rationale for bad behavior as personal shortcomings. And so adolescent depression then is, in the best case scenario, in the evidence-based practice world, managed by a specially trained multidisciplinary team. And so that means that individual treatment for kids is highly individualized. I don't think I have any kids on the exact same regimen for depression or anxiety. There's a lot of off-label use of drugs, and that's another piece to that. But overall, in the best world, with resources available, the best treatment for adolescent depression is going to be some combination of counseling, individual counseling, psychotherapy, family therapy, cognitive therapy, education, environmental changes in the home, and pharmacotherapy. So there's a lot of things happening. But for adolescent depression to exist, a lot of things had to happen. And it's not just one thing. It's a cumulative effect. And so that cumulative effect has to be addressed in the treatment for it to be successful. And that's important, the successful piece. If we just gave everybody medication, outcomes would be even worse. Because it's not just, medication's not just a Band-Aid that you slap on to fix it. And so what I tell my patients, especially because teenagers don't want to take medication because that makes them different, they feel embarrassed, they feel reliant, they want to be like their peers and not have to, take medications, etc., etc. The way that I explain it to teenagers who need to be on something for depression or anxiety is I draw the equivalent to a broken bone, because it's very easy to see. It hurts, you can see that there's a problem, you can get an x-ray, you can visually see the problem. With depression, it's different, and the perspective is very different. And so I had this conversation just at the end of last week with somebody who wanted to stop all of her medications. And she actually was had recently been to OPA for a broken ankle, and so I was, I said to her, you needed a boot, right? You needed a cast. You broke your ankle. Oh yeah, absolutely. I said, if you took that off, do you think it would hurt a lot? And it would, like, what would that be like? She says, no. I don't want anybody to touch this. I want this to stay on. Okay. Well, what about your depression? Can you see that? Well, no. Do you feel it? Oh yeah. What about your medications? And she was like, well, what do you mean? And I said, well, you know that you need the cast or the boot for your ankle because it was broken. Do you acknowledge that you have depression? She did. I said, okay, so what's the difference in wearing a cast for a broken bone and taking an SSRI for depression? She just kind of looked at me, and I got one eyebrow raised and kind of like a non-response response. And so I plunged forward and took advantage of her semi-acquiescence and said, that's exactly it. Are you going to wear the cast forever? She said, no. It's going to come off in maybe like 6 or 8 weeks. I said, okay. Do you think you're going to be on medication for depression forever? And she said, well, I just don't know. And that's why it's scary. What I always tell teenagers is that the goal is never for them to be on medication forever. And that's usually the piece that they struggle with the most, is the medication. It might make them feel a little bit different, but really, again, it comes back to being different from everybody else and having to take it. And so I tell them, it's just like a cast. You wear it until you don't need it, until the healing process has completed. It's just easier to see and feel a broken bone that's healed in comparison to depression. And I remind them too, depression is not just I had a bad day. depression is a chemical imbalance. There's in the brain, there's something happening that's not supposed to, and the medication helps address that. You just can't see it. Most of the time, they will at least, my patients will at least consider that explanation and will continue taking their meds at least for the next month until I see them again. Not everybody, but most of them. The other way that I explain medication is, you know, sometimes like if you're hiking, and because almost everybody hikes, you're hiking and you're almost to the top, but you're so tired, and sometimes you just need someone to give you a hand and pull you up. You just need a little extra support. That's what the medications do. It provides a little bit extra support. And so all of this to say, this goes back to the nursing consideration of communication and therapeutic relationships. It is so imperative, especially in teenagers who are resistant to talking and communicating. School-age children may not know how to even express their feelings. They may not have the words to do so, and this is where that communication is so important. Understanding how to talk to teenagers, understanding how to connect with them. Neurobiologically, adolescents, and I've done the research, they literally, chemically are predisposed to only thinking about themselves and what they want. They have an overabundance of dopamine, so they just want to feel good and do what makes them happy all the time. Forget everybody else. And so knowing that helps me understand how to talk to teenagers and get them to understand what I'm saying. And that's something that even if you don't want to be a pediatric nurse, it usually comes up. Somebody wants to be an ER nurse. And I know from the journals there are a lot of individuals in here who are interested in pediatric nursing. And this communication piece is huge with patients and with families. And it takes time and it takes practice. I didn't come out of the door day one from nursing school and was like, yes, I know how to talk to teenagers. Kind of, because I had talked to a lot of teenagers while I was in undergrad through volunteer and stuff, but not everybody does, and that's okay. Somebody in their journal had written that they felt concerned that that's kind of the hands-on piece that you guys are missing with not being in clinicals, is just how to talk to people. I can understand that, especially as I keep preaching to you that communication is a huge piece of this. But please know that that will come with time. Just like learning how to talk to teenagers about depression or brushing their teeth. It comes with time. So, moving on a little bit, here I have the 2017 Alaska Youth Risk Behavioral Survey results from the mental health component. So, every other year, the state surveys teenagers. And it's usually the traditional high school students, so they are finally trying to capture the non-traditional high school students. And there's a whole bunch of different questions and like sections in there, topics. I pulled out all of the mental health results. This is from my thesis project for my DNP degree, part of my like 100-page manuscript. I pulled this out of there. That's why I'm quoted at the bottom, if you're wondering. It's not to be weird. These are actual data points from Alaska from 2017, from the responses of teenagers. Anything that's bolded in black was an increase from the 2015 results of 1% or less. Anything that is bolded in red is an increase of greater than 1% from the previous year's results. And so as you can see, 99.9% of these data points had an increase of some kind. I found it particularly concerning that most of the areas, all of the areas for the females had increased, but the females had the highest percentage of increase. And so when you look at this, I found it pretty stark as a community member and as a nurse. And actually, this is what spurred on one of the biggest pieces of support that I had for my DNP project. And this is, we're looking at things like Healthy Alaskans 2020 and Healthy Alaskans 2030 and Healthy People 2020 and 2030. This is real life examples of how that objective information, how the data that's collected for that is used in real life, real practice. You see an issue, you find the data that demonstrates the gap in the need, and then you create an intervention and you implement it. I created, totally aside, and we're at almost 2.5 hours, so real quick, I created a community-based adolescent mental health promotion curriculum for any teenager, not just people who have like depression or anxiety. It's for anybody. It has its own conceptual framework. It's evidence-based. It's adaptable for any setting, like an after-school project or an after-school program or in the schools. And it addresses all of these pieces that I've been talking about: healthy relationships, consent, problem solving, critical thinking, communication, bullying, teen dating violence. And it provides a way to have non-judgmental conversations in a safe space. Because our suicide rates for teenagers continue to increase despite it being an objective, almost, we're on to year 5 now. It's an issue. And it's an issue nationwide. It's not just Alaska. We just happen to have a higher percentage of it. So as I continue to harp about communication and assessment, and taking things seriously that your patients say, this is where that's coming from. We shouldn't just assume that teenagers are moody and it's okay for them to be upset, and kind of that ongoing cascade of stereotypes. As the nurse, it is your job to talk to them, to assess them, hopefully in a way that they don't realize they're being assessed, because that would be the best case scenario. But that's how we capture individuals at risk and how to help them. And so there is a huge substance abuse issue with teenagers as well. Again, I'm only going to briefly just talk about this. So there's drug abuse, there's drug misuse and addiction. Misuse and abuse. I wonder if you're wondering kind of what the difference is. So a drug abuse is going to be that chronic, incorrect, or misuse of drugs. There can be drug misuse without drug abuse, related to how often it's occurring, how many occurrences there have been. And then there is addiction. There is that psychological addiction. And then there is drug tolerance and physical dependence. So also very different things. The types of drugs, I mean, there's so many. There's your regular alcohol, narcotics, depressants and stimulants, cocaine, hallucinogens. I was just doing a CE thing the other day and heard that in other areas of the country, psychedelics are being used more often again. But also things like chocolate, tea, pop. That's not usually considered a drug by society, but it is considered and falls under substance abuse depending upon how it's used and how often and those kinds of things. I put a star next to vaping because many of you had mentioned that. You found that kind of surprising, or that was something that you picked up on in week 1. With the eye to vaping versus tobacco smoking products. And it is a huge issue. I kind of got a backseat to COVID, like everything else. But the education and continuing education that's coming out both for providers and nurses about vaping is ongoing. There's so much that we don't know, and what we do know is kind of scary. I'm talking, extreme cases, double lung transplant at 17, 18, 19 years old related to vaping. So lots of pieces with this. I connected the substance abuse under mood disorders because it has to do with behavioral issues and modifications. Again, you should get more of this later on in the semester in psych. I'm not going to be asking you a lot about it. If I do, it's going to be kind of in that inner application type capacity, like with those case study examples. Okay, last couple things here. Chronic and complex medical issues in children. I really broke it down to the most basic pieces here. Support systems, developmental impact, and coping. Huge. Families with kiddos with chronic and complex medical issues have a myriad of considerations that have to be taken into consideration for simple things like going to the store, to trying to plan vacations is huge. Developmental impact, obviously we're going to talk about that for everything, but here, you know, is this a child that was diagnosed early on in life and they grew up with this, or is this a child that was diagnosed with something later, like a later onset issue, and is now adjusting to that? So these are the three pieces that I want to encourage you to focus on in the reading for this, and understanding what your role as the nurse is. So palliative care in the dying child, again, I love tables. So table 17.4 I thought was a really good one. Palliative care and the dying kiddo is challenging for everybody. As the nurse here, you're going to be taking care of the child, the parent, and if there's a sibling, the sibling. And what is the sibling reaction here? How is that sibling impacted? What about the parent and their reactions? What does that look like? What is the child's understanding and reaction to death? I put down here, refer to the case study. There is a case study about palliative care in the dying kiddo that addresses all of this stuff. So I'm not going to spend a lot of time on it here because you're going to get it in the answer video. But as you're doing the reading and prepping, these are the things to focus on. Okay, last thing actually. Briefly, I want to mention autism. Again, I'd feel remiss if we didn't. I believe you get much more of that in psych though. So this is another one of those unknown etiology pieces. And I hate the way that this next one is phrased in the book, but core deficits in social interactions, communication, and behavior. I really hate the deficit conversation. But be that as it may, kiddos with autism somewhere on the spectrum will struggle to have social interactions, communication, and behavior that is considered developmentally appropriate. That's how I would prefer to say it. I mentioned the spectrum piece. If anybody did not know, autism spectrum disorders fall on a spectrum from, almost fully 100% functioning with very little impact on their daily life to those who are going to need round-the-clock care for the rest of their life. It just really depends on where they land, how early intervention is started, their response to that, those kinds of things. Autism has associated physical impairments or impacts that we know of. Big ones fall under the GI system. Constipation is a big issue. I have a cousin who is adopted, whose bio mom did, we don't even really know truthfully how many substances she abused while she was pregnant. And my cousin was born with FASD, so fetal alcohol spectrum disorder, autism, and he has a slew of other diagnoses. And he is further down on the functioning part of the spectrum, and he has struggled with GI issues his whole life. He also struggles with hormonal issues once he hit puberty. So there's a lot of impacts. And he has a lot of comorbidities. It's not just that my cousin has autism, but he has all these other comorbidities, but that's very common as well. And so the family and social support that's offered to patients who have somewhere on the autism spectrum is monumental to their outcomes and more positive outcomes rather. Family support groups, social groups with people who can truly empathize and sympathize with what they're going through. That's a big piece for the patients as well. And so, again, a brief overview. We're not going far deep into any of that stuff, but I want you to consider it for the school age and adolescent, and how the development, the normal growth and development here is challenged, and what that would look like for them. So, lastly, I don't do a blueprint. I know people have asked. I don't provide one. But what I will say are these things about the first exam. So reviewing those main tenets of health promotion for each age group. I feel like I have preached about this quite a bit, but that goes back to your priority buckets: safety and injury prevention, nutrition, sleep, communication, therapeutic relationships. What does that look like for each age and stage? And I hope now you have a better understanding of how that's broken down and what that looks like after this PowerPoint. Big emphasis on how Erikson and Piaget, because we talk a lot about the cognitive impacts, how this is applied to each age group and everything that you're going to do as a nurse. Okay? The case study questions in this PowerPoint, I hope, illustrate a little bit better for you how all of these pieces fall together in one summary type synopsis question. Please do the learning activities for this module. If you do those and you spend a good amount of time on the group case study assignment, you'll be sitting in a really good place for the exam as well. Practice your math. There's a good quantity of math calculations on this first exam. There's some on the second exam too, but there's more on this one. And repetition. Someone in your class in their journal explained to me their study plan, and it's almost verbatim what I tell most students. You need that repetition. You've got to listen to the PowerPoint, take your own notes, and then look for other sources. Hear it in a different way so that it makes more sense to you. And what does that look like for you? It could be videos, it could be drawing concept maps, it could be verbally discussing it with a classmate, it could be all the above. If you feel like you could teach somebody the content in your own words, not my words, not verbatim from the book, but if you could teach somebody this content and you could explain why Erikson's theories are so important and how they're applied to each age group in a quick 5-minute synopsis, you're going to be sitting much better for the exam than if you were to recite it off of the pages verbatim. So that's what I have for Module 3. I hope that you all study hard, take advantage of the extra time that you were given last week, and please reach out with any questions. I hope you guys have a great day.